So I have 10 minutes. I'm going to talk about radioligand therapy, but I'm really going to focus on lutetium PSMA. And if there are questions about radium-223 or other future radioligands, I'll be happy to take those during the Q&A. Okay, so using lutetium PSMA as an example, what is radioligand therapy? As the name implies, it's a treatment that combines a radioactive isotope, so an element that emits cancer-killing radiation, bound to a ligand molecule, something that helps to direct your treatment inside of the cancer cells. In the case of lutetium PSMA, we have lutetium-177, and it's bound to PSMA-617, which helps to deliver the radiation of the agent inside of the prostate cancer cells. PSMA, we've probably covered this before, but it stands for prostate-specific membrane antigen. So it's really a receptor that you find on the surface of prostate cancer cells and in very few other parts of the body. So it's a good target for us to get our treatments to the cancer while minimizing toxicities. And in particular, once lutetium PSMA binds to this receptor, to the PSMA receptor, it actually gets internalized. It's taken up inside of the cells where the drug accumulates, emits radiation that then causes DNA damage and kills the cells. One of the key features about radioligand therapy is that once you have a target and once you have a small molecule that can get a radioactive element inside of the target, it's very easy to have both a therapeutic agent with cancer-killing radiation like lutetium PSMA, but then also to have a diagnostic agent where you use something like gallium-68, which emits benign radiation, so it doesn't do anything to the body, but you can detect it on a scanner. So this is an example of why this matters. This is a concept we refer to as Theranostics, or the idea that with radioligand therapy, you can see what you treat and treat what you see. So you can see the leftmost figure here shows a baseline PSMA PET scan for a patient. All the black spots are PSMA avid or expressing tumors, metastases. The next image to the right, cycle 1, is after the same patient receives his first dose of Pluvicto the next day, you can actually image. So this second scan, cycle 1, the patient did not receive a PET tracer. They were given Pluvicto. You're actually able to detect the radiation that's being emitted by Pluvicto. So the first two images look very similar. You're just seeing the same amount of disease, first with a PET tracer and then with Pluvicto. But what you can see is as you treat the patient with each subsequent cycles, every time they come in and you image with Pluvicto, you can see in real time almost the cancer burden diminish as the patient responds to treatment. The other way in which this is helpful is upfront in patient selection. So you're able to look at a PET scan to make sure that the person you're seeing in front of you is going to be a good candidate for lutetium PSMA. This is an example here. So the leftmost figure shows, again, a PET scan, a PSMA PET scan. So you see widespread PSMA-positive metastases. But then when you do a sugar PET scan in the same patient, where you're just looking at parts that are metabolically active, and you put the two side by side, you can see that there are liver metastases that are metabolically active, but do not show up on the PSMA PET scan. So this is actually an example of a patient with PSMA-negative liver metastases who will not benefit from Pluvicto. And being able to know that up front before even recommending a treatment is really invaluable. Now, fortunately, this example is to highlight the point. It's really only a minority of patients whose cancer does not express PSMA, but it's still something that we're able to check before we embark on this treatment. I'm going to talk about 3 trials to kind of place lutetium PSMA and radioligand therapy in the treatment landscape for advanced prostate cancer. The first one is the VISION trial. So this was a study looking at patients with hormone-resistant prostate cancer who had progressed on an AR pathway inhibitor and who had also progressed on chemotherapy. So these patients were randomly assigned either to receive standard of care, mostly supportive measures, or 6 cycles of Pluvicto. And the study was positive. The treatment with Pluvicto was associated with almost a 60% reduction, these are relative reductions, but in the risk of progression, and a 40% reduction in the risk of death compared to the control arm, which resulted in an improvement in median overall survival from about 11 months to 15 months. And following the results of this study in March of 2022, the FDA approved for the first time Pluvicto as a treatment option, initially for patients who had progressed, as I said, on an AR pathway inhibitor and on chemotherapy. So if you think about the treatment landscape for prostate cancer, this is where the VISION trial established lutetium PSMA as a treatment options. And as you can imagine, then the next question is, well, if it works after chemotherapy, could we also give it to patients before they've received chemotherapy? And there were 3 trials that looked at this. We actually at UCSF participated in the ECLIPSE trial, but I'll talk about PSMA-4, which was the first to present results. So similar to the VISION trial, these were men with metastatic prostate cancer who had progressed on an AR pathway inhibitor, but they had not yet received chemotherapy. So participants in the control arm, the experimental arm, they were given 6 cycles of Pluvicto. In the control arm, we used an ARPI switch strategy. So if they had progressed on abiraterone, they were switched to enzalutamide or vice versa. The primary endpoint of that study was progression, and the risk of progression was significantly reduced by almost 60% with Pluvicto relative to the control arm. And the median time to progression was more than doubled. Now, this study had a crossover. So the participants who were given an ARPI switch, so started with another hormone therapy pill, once they progressed, provided they were eligible, they were offered Pluvicto. So as a result, there was no difference, significant difference in overall survival as long as participants received Pluvicto at some point. But nevertheless, following the results of this study, about a year ago in March of 2025, the FDA expanded the label of Pluvicto to allow it for patients with hormone-resistant prostate cancer who had not yet received chemotherapy. So when is the best time to offer radioligand therapy for our patients? I will say we've shown a benefit in the VISION trial for using Pluvicto after chemotherapy, and then in PSMA-4 for using Pluvicto before chemotherapy. But the optimal sequence, whether someone should start with Pluvicto and then get chemo or vice versa, is still unknown in many ways. There are not a lot of large head-to-head comparison looking at Pluvicto versus chemotherapy. What we've seen in some of these trials is that on average, Pluvicto is more likely to achieve a PSA response, but it's not clear that there's a major difference in overall survival between chemotherapy and Pluvicto. What is clear, however, is that side effects generally are much fewer with Pluvicto, and so this is looking at patient-reported outcomes. And you can see the point of that figure is that on almost all of these metrics, when patients were asked about functioning, symptoms, their quality of life was improved when they were receiving Pluvicto compared to those who were receiving chemotherapy. So although there are still questions about the optimal sequence from a purely cancer efficacy standpoint, we tend to offer our best therapy first. And for most of our patients, given that Pluvicto is much better tolerated, this often means that once they progress on an AR pathway inhibitor, the first treatment they will get in the castration-resistant setting or hormone-resistant setting will be Pluvicto. So going back to the landscape, then, as you can imagine, the next question is if it works in the hormone-resistant setting, could it be beneficial for patients who haven't yet progressed on hormone therapy? And I'm just going to talk about one study here, PSMA addition, since we are starting to have some results. So this is a study looking at over 1,000 participants with newly diagnosed prostate cancer, metastatic prostate cancer. Everyone was treated with a standard of care treatment, so ADT with an AR pathway inhibitor, but the study asked or looked at the benefit of adding 6 cycles of Pluvicto at this stage. The primary endpoint was risk of progression, and it was significantly improved or delayed with Pluvicto by about 28%. There's a relative risk reduction. I will say, as we, I think, alluded to, so far, we've not yet, it's too immature, so we do not yet know if there's an overall survival benefit. Are our patients actually living longer by getting Pluvicto earlier? We know it's an effective treatment, so in some ways it's not surprising that progression is delayed if you give it up front. But the real question, whether it improves survival, we still do not know. And if you look at quality of life, it actually seems like there was at least no benefit and potentially worse quality of life in the men treated with Pluvicto up front. I'll just conclude thinking about ways we can improve lutetium PSMA radioligand therapy. And I think for this, it helps to think about mechanisms of resistance. So why does Pluvicto not always work? One mechanism is you may have cells that express some PSMA but not enough. And so we use PET to select patients appropriately. But there are also trials looking at combinations. Are there other medications we can give with Pluvicto that are going to increase the expression of PSMA so that more of your treatment gets inside of the cancer cells? There are cells that express plenty of PSMA but are just inherently more resistant to radiation. And so for those, we're looking at combinations with therapies that will sensitize cancer cells to the effects of radiation. And for both of these mechanisms, also looking at either higher doses of Pluvicto or radioligand therapies with a more potent payload instead of lutetium-177. And then the last mechanism is there is heterogeneity. You may have tumors that light up on a PET scan that express PSMA in some of the cells, but in there you can have cells that don't express any PSMA. And there's a lot of work going on right now trying to use the same approach but with different targets that may be complementary to PSMA. I'll finish here, but this is a summary. I think for time I'll leave that up, but happy to take questions afterwards. Thank you.